Hello, everyone. Good afternoon. We're really happy to be with you this afternoon. This is something that I've been looking forward to for ages. And JD, thanks again for your really stimulating and dynamic presentation. I'm excited for the opportunity to now have a panel discussion about using the implementation research logic model, specifically highlighting examples from scholars here at the University of Wisconsin in Madison. I'm Andy Garbitz, and I'm just really honored to have the chance to moderate this panel here this afternoon. JD has agreed to be the discussant for our panel to offer some insights and words of reflection and conversation that will help guide some of our discussion following the panel presentations. So we're going to move forward now, and I'll just ask each panel member to briefly introduce themselves, and then we'll start with our first set of panelists that will be followed by our second set of panelists, and then a discussion and conversation. Great. So we can just maybe go down the line and allow everybody.
My name is Olayinka Shiyanbola, Associate Professor at the School of Pharmacy.
Hello, I'm Martha Maurer. I'm a scientist in the School of Pharmacy, and I have been working with Dr. Shiyanbola for about 5 years on her projects.
Good afternoon. Can you hear me? Is it on? Yes? Okay. Good afternoon. My name is Earlise Ward. I'm a professor in the Department of Family Medicine and Community Health and a psychologist by training.
Hello, my name is Felice Resnick. I am a scientist in the Dissemination and Implementation Launchpad, and I also work with Dr. Ward as a scientist on her project that we'll be talking about today.
Great. Thank you, everybody, for those great introductions. So now we'll move to our first set of panelists. And just a reminder that we will have an opportunity, again, facilitated by our colleagues here to have a question and answer and conversation section following the two sets of panel presentations.
Can you all hear me? Good. Perfect. Okay, so again, good afternoon, everyone. Today I'm going to be talking about a project called Healthy Living for You, which is our culturally adapted healthy living with diabetes. I'll tell you a little bit more about that for Black adults. So to give you a little bit of a background, you already know the stats. We know that Black adults are more likely to have high prevalence of diabetes and also more likely to develop diabetes complications such as stroke, kidney disease, and heart failure. Something, however, that we also know is that to be able to manage diabetes and have diabetes control, it is recommended from the American Diabetes Association and from the CDC that you do need to participate in diabetes self-management programs, which in this case called DSMP. And when they go to these education classes, they are able to learn how to manage their diabetes, understand what the disease is actually about, and what are some of the steps they need to take to be able to achieve glycemic control. However, we know from prior studies that there are unique barriers that actually makes Black adults less likely to participate in this program that is already evidence-based. So in the state of Wisconsin, the diabetes self-management program that we have is called Healthy Living with Diabetes. It is a 6-week program. It is endorsed by the CDC, and there is actually evidence to show that it actually does help with bringing those blood glucose down and actually reduces emergency room visits. And so we wanted to understand if there is a program that is already evidence-based, it works, what is it and what are those barriers that actually makes Black adults less likely to participate? And so we did a little bit of a pilot study using human-centered design, which we talked about, I think, in the last D&I conference last year. And we did interviews with different key stakeholders. We brought together patient stakeholders who were represented, Black adults with diabetes, community organizations that serve Black adults, and also brought in the Wisconsin Healthy Living with Diabetes Purveyor, which is the program, the organization that actually disseminates healthy living with diabetes across the state. And these were some of the things we found. We found that there was limited trust. And just so you know, we identified different barriers, but for the purpose of this study, we identified patient barriers, system barriers, but for this study, we focused only on patient barriers. And one of the things we heard is that there was limited trust with the individuals who are actually leading those workshops and leading the sessions because almost all of them racially identified as white. At the time of the study last year, there was only one Black active facilitator in the whole state of Wisconsin that actually leads these programs. And so all the other things they talked about is that there is a lack of a culturally relevant approach, and you can see some of the quotes from those interviews. The food is not common to all ethnic groups that are in the book they're supposed to be reading. And also they were having them read from the book. They were telling the facilitators to read from the book, which was required as part of the training. And so we knew that we needed to tackle this issue. And this was important because we know that when Black adults don't participate in programs, it leads to poor health outcomes compared to non-Hispanic whites. And we also know that if we are going to address these barriers, we need to think about what are those culturally relevant approaches that we have learned about. And so what you see is an example from a design thinking participant from our prior work saying, well, you need to teach the content like somebody who is actually educating people in a way that actually works for them. And currently, the Healthy Living with Diabetes program and content is a one-size-fits-all approach. And so the objectives of our project is, first of all, bring together stakeholders through a co-design process where we want to think about what is the culturally relevant approach to how we recruit more Black facilitators, considering that there's only one in the state of Wisconsin, and also how do we train them in culturally relevant ways of leading the workshop. And then our second aim is also now taking all we learned and now implementing a tailored program to assess reach, feasibility of adoption, participant adherence, acceptability, fidelity, and also effectiveness pre-post diabetes outcomes. Okay, so now I'm going to walk you through the process of our Healthy Living for You implementation research logic model. And so kind of like what JD talked about, we started off with what exactly our determinants, what are our barriers and facilitators. And as you can see here, we kind of color-coded actually our barriers. And you can see that where you have the blue coding is actually the barriers. And then the I, which is actually colored red, was actually the facilitator. And so what you can see is there's a lot of barriers, right? Because we only have one colored red. And some of the things we found from those design thinking, we didn't use CIFR, just so you know. We used the pilot work. And we found that things like the content needs cultural adaptation. The program delivery is not tailored to Black adults. It's challenging to even identify and even recruit Black facilitators. A lot of programs that actually serve the community, that serve the Black community, there's not even anyone that wants to host the diabetes self-management workshop. And then there's a lack of knowledge. The only facilitator that we identified was that there are people in the community that have actually participated in the program. How do we bring them back together to be facilitators? And so we knew that that was a way we could leverage that was one facilitator we could leverage. Now, going to the implementation strategies, we used the ERIC strategies, and we had two. The two main strategies we had was increasing the community capacity to identify and recruit these facilitators using these asset-based community engaged strategies. And using the ERIC strategies, you can see we had the using advisory board, which was our co-design of bringing those different stakeholders. We were going to be talking about working together and building those relationships. And then under the second strategy is we want to provide adjunct training. We don't want to change the Health Living with Diabetes training because we know that's already evidence-based, but we want to provide more training on how to deliver it in a culturally appropriate manner. And you can see that we mapped all our barriers from the left side to the implementation strategies. And the ERIC, using the ERIC model actually helped us think about what are the strategies to use. And then to our mechanisms. What is actually going to happen when we actually tackle those barriers? And you can see, for example, we also mapped that to now we are going to be able to increase more Black and recruit more facilitators. They're going to have increased self-efficacy to actually teach the content in a culturally appropriate manner. And then more organizations that actually serve the Black community are going to be interested in hosting the sessions. Now, for our outcomes, we used both the re-aim and the proctor outcomes. However, we didn't use all the elements, so I was so glad to see JD say that. For the re-aim, we only focused on reach and effectiveness. And so for our reach, we are using a mixed methods approach. And so we are doing both qualitative and qualitative approach to look for participant recruitment, retention, and therefore the proctor outcomes is represented on the red, which is our adoption, our implementation, and our satisfaction. And so one thing I would mention before I pass it over is we did our IRLM logic model retrospectively after we got the funding. And one of the things we actually found is that it was so helpful in helping us sort of map our process. And now we are actually going to go back, because now that we've started our co-design, we are beginning to see that there are some strategies that we didn't have in there, and we need to add that on. And so that is also a way of showing that even our logic model is going to evolve throughout the process of the project. And so I'll pass it on to Martha.
Great, thank you. So now I will share a little bit about our experience so far and what our plans are for the remainder of the project. So regarding implementation strategy 1, so as a quick reminder, this was increasing the community capacity to recruit Black or African American facilitators for the HLWD program. So we have this strategy of we convened a stakeholder advisory board. There are 12 members, and you can see some of the membership there: a parish nurse, for example, a pastor, barbershop owner. And then importantly, we have a set of stakeholders who have direct experience with the HLWD program. So we have patients who are living with diabetes who have been participants in the program in the past, as well as individuals who were formerly facilitators for the program, so they can share those direct past experiences as well. And you can see here, as Yinka mentioned, in some of our developmental work where we had these focus groups and interviews, these were some of the quotes really pointing to that need for engaging with the community and how important it is for the stakeholders in this project. And then finally at the bottom, these are some of the questions. So I should say we've had 2 of our co-design meetings already. We have 3 more to go. And these are some of the questions that we've been considering with the group so far. So, could we engage with past Black participants in the HLWD program and invite them to take the training and become facilitators themselves? Or similarly, could we engage with individuals who in the past were facilitators and maybe their status is now, we know that some exist, but their status is inactive. So how can we get them interested in becoming, getting that booster training and then becoming facilitators again? So regarding the second implementation strategy, this was to actually implement the training. So I will say out of the co-design process, we hope to develop that training together. And then with the second strategy, we will actually implement the training and train the Black facilitators on these new culturally tailored methods. So again, it's this idea of giving the facilitator, this was another quote from our early developmental work, where we're giving the facilitator the guidance and the tools to really be able to relate the core evidence-based curriculum to their target audience and their community. And so again, what's next? So after we complete the co-design process, we will be moving ahead with the second phase of the project, where we're going to be implementing the HLWD program, or the training program, and then we'll be conducting 2 separate 6-week HLWD workshops with those trained facilitators. And then as Yinka mentioned, we have an embedded mixed methods design to then evaluate some re-aim and some of the proctor implementation outcomes. We're very fortunate to have a number of wonderful partners in this project. So some likely look familiar. So the Community Academic Aging Research Network has been instrumental in helping us develop that stakeholder advisory board. The Wisconsin Institute for Healthy Aging, they are the statewide purveyor of the Healthy Living with Diabetes program for Wisconsin. So they're an important partner as well. And then in Milwaukee, we have 3 community partner organizations, Grace Fellowship Church and the YMCA. They have agreed to actually host the HLWD workshops in that second phase of the project. And then Unite Wisconsin is also an integral partner. They are part of the Stakeholder Advisory Board. And they have a rich experience with implementing HLWD in the Milwaukee area, so they're able to provide that perspective. And then finally, just sort of expanding a little bit upon what Yinka was mentioning, our experience in applying this model and sort of what we've learned. You know, we could foresee that this would be really helpful in our next grant application. In fact, we were just chatting about it earlier and how we could use this model to then map out, you know, what's our next step after we complete this current project, and perhaps think of it on a multi-level. So thinking about referrals into the program through healthcare systems, what might be our next approach. We also feel like it would be useful within our own team currently to sort of explain the rationale between some of our design elements and why we're taking these approaches, so that our whole team understands. Certainly it's helpful for tracking data and knowing, you know, at the front end what's important to measure and track. And then, of course, for manuscript writing, we think that it's really going to be helpful in sort of telling that complete story, so that people really understand, readers understand the conceptual linkages between, you know, why we use certain strategies, what the mechanisms were, and then the outcomes we found. And with that, we'd just like to thank you for being able to share our project. Thank you.
Thank you so much to our first panel presenters. We'll invite our second panelists up now.
Thank you. Okay, I will be talking with you about a faith-based depression intervention that we've developed. It is an effectiveness and implementation trial. Next slide, please. Working with the technology. So I will start by providing just a brief background on this work. Major depressive disorder, also known as clinical depression, is one of the most common, costly, and debilitating psychiatric disorders in the U.S. The World Health Organization identified clinical depression as a leading cause of disability. And we have data indicating that the 12-month prevalence of clinical depression among African Americans and whites are similar. However, what we see is that African Americans tend to have higher rates of chronicity as well as disability associated with clinical depression. And with that, despite the burden among African Americans, we are seeing low use of mental health services, and their use is actually lower than white individuals. Research indicate that low use may in part be due to poor quality care as well as lack of guideline concordant care for that population. And so research indicate that although African Americans show low treatment seeking, they tend to be interested in religious coping. And in fact, in some of my own research, we found that they're more open to going to their pastor and asking for prayers and support around the mental health issues they're dealing with. They're actively involved in the church, hoping that those things will help with the issues. And so in some of my work, I do community engaged work. And so I started connecting with the pastors to help them understand mental illness. And in the process of helping them understand depression, they started contacting me saying, you know, Dr. Ward, we're really learning a lot about depression and we appreciate you. And I have folks coming to me asking for spiritual guidance. And as I listen to them, I'm realizing this is not an issue for spiritual guidance. This is a person dealing with mental illness, possibly depression, and they can use some help. And so I'm going to call Dr. Ward. Well, I got a lot of those calls, and at the end of the day, I'm only one person, right? So I had to be transparent, saying really appreciate the fact that you're learning and valuing mental health and really supporting your congregation, but I'm only one person. So let's think about how we can sort of come together to address these issues. And so with that, I formed a faith-based community advisory board, and we came together and worked on developing a faith-based depression treatment. It is 12 weeks of group counseling, and you can see the modules there, addressing various aspects of depression. You'll notice in the first module, we do sort of an introduction and an overview of counseling and what does that all entail, because we were finding that folks were not going to get treatment, so they didn't understand the process. And the folks who did go, they dropped out prematurely, and so still didn't have a good understanding of what that all entails. So we, as you'll see, all of our models have different aspects where we heard that there are gaps and people don't understand, and how do we provide more information to help them better understand depression, and more importantly, learn healthier coping behaviors, if you will. So that's our 12-week depression intervention. It is done as a group. What we learned from our faith-based community advisory board is that the intervention must be delivered at on a church site, because that's where people feel most comfortable. So increasing access that way, and that the intervention must be delivered by a mental health clinician as well as a pastor. So once we develop the intervention, then the next step is to get funding to then begin to do our efficacy trial. So aims, first primary aim is to examine effectiveness of the intervention in reducing symptoms of clinical depression. Our measures include the PHQ-9 as well as the QIDS, which is a quick inventory of depression symptoms. And aim 3 is really aim 2, where we will be examining moderating effects of religiosity. And along with that, you'll notice in that hypothesis, we are hypothesizing that people with higher levels of religiosity may be associated with better or higher reduction in depression symptoms. But again, this is new, so we will see what happens here. And then aim 2, we will be using the RE-AIM framework to examine reach, adoption, implementation, and maintenance of the intervention. Design, this is a hybrid type 1 effectiveness implementation trial. This design provides simultaneous testing of the intervention as well as the implementation aspects of the study. This design that we're using will allow all participants to get access to the intervention. We thought about a randomized controlled trial, but there was some concerns that my statistician had, so we ended up going with this model that allows for every participant to receive the intervention. We will have a sample of 120 participants, and we will be working with 5 churches. And I will turn things over to Dr.
Hello. So in doing this as a type 1 implementation hybrid design, we are kind of looking at what do we hypothesize. It's all exploratory at this point about how this work will map onto the IRLM. And in some prior work, Dr. Ward has worked with her CAB, her Community Advisory Board, and received some information from participants about what barriers and facilitators they have experienced in the past in receiving mental health care. And so we have taken that information to kind of hypothesize what we think we will see here. And to the point of what others have said about the utility of the IRLM is that we can then use this going forward as we gain new information from the participants and from the clinicians and from the CAB to fill it in and understand what are those true barriers and facilitators as we do some interviews with the different folks who are involved. And then also as we come up with and brainstorm strategies, doing that process of what we think would be the most feasible, et cetera, for that next study. So to walk you all through it, this is kind of our comprehensive full version where we were hypothesizing all the things we think we might see. And so we indicated our facilitators as the ones in green and the barriers as the ones in orange. And then there's some things we don't know. They might be case neutral as was described by the Dan Schroeder article, where we're just not sure what we're going to see. We also came up with a list of strategies based on ERIC that we think we might be using, or we already exist in the environment. And so that's why we listed them here. And those are things like assessing for readiness of the church setting to have the intervention delivered. What is already, and we're going to be doing this pre-implementation, trying to assess readiness. And that we already knew we were going to do, so we're including that as a strategy. We then came to our mechanisms, and we were confused. We sat there thinking for a long time about, okay, we have these hypothesized strategies, we have these outcomes, but what is that thing? What is that black box of how this will actually work? And so we came up with some hypotheses, and JD, we're thrilled to hear that you're going to expand upon what those mechanisms are, because while we came up with a lot of ideas, we're wondering how we can actually test that or know for sure. And so that's how we filled in this part. And then we got to our outcomes, which Dr. Ward articulated, center around the REAIM frameworks of reach and adoption, and then our clinical effectiveness outcome. What I now want to also walk us through kind of quickly is that idea of the pathways. And so since the key here is understanding the pathways of how these all connect, we kind of made a more simplified version that focused on 2 key pathways that we think are going to be, we will find while laying it out on the IRLM. So what you can see kind of by these pink stars are, we think that there will be a facilitator that this CV Faith intervention comes from a trusted source, since it was developed with the faith-based community advisory board. That faith-based community advisory board provided insights and feedback onto the development of the modules. And so we think that that will be a facilitator of the adoption of the intervention. We then thought, okay, we have these facilitators, and we've listed a couple of more. And what are those strategies we can use to leverage those facilitators? One strategy we thought we would leverage is using the CAB and community partners to identify different marketing strategies that increase, strategies that increase knowledge and trust of the intervention. So how can we get folks to come and be part of this intervention? We will leverage that CAB. We then hypothesized that these mechanisms, the why would this work, is by having trusted community partners, they are likely to increase the willingness of individuals to participate and will enhance reach, which would then increase the outcome of reach. And now there are many stars here because we anticipated that this one strategy would actually leverage several different facilitators and lead to several different changes in outcomes. What we will likely find is that not all of this works quite as we thought. That when we actually go to do our interviews with the practitioners and with some of those who are receiving the intervention, that they might mention different facilitators or different barriers that are things that we need to address. And some of these strategies that we think are really going to be high priority may not be the priority to them. And so what we expect to do is in time work with these different groups to keep iterating on this IRLM to kind of come up with our final version that we can then use in our next study, in Dr. Ward's next study, where we're really able to test those implementation strategies once we have received feedback from all those groups. We have found this to be a really helpful way to really organize the different hypothesized pathways for this type 1 hybrid study, where this is all exploratory. We're trying to understand what is happening. And then in our next one, we'd really test those strategies. So we're happy to kind of discuss this more. Again, we're just trying to start to use this, and we thought it was a really exciting way to share how we've found utility in it. And so we'll have some more time to answer some questions. But I also want to make sure that we thank and acknowledge all the folks who have helped with Dr. Ward and her ability to do this project. And so thank you to everyone. And I will now turn it over to our discussants.
Thanks so much to our second panelist. So in a few minutes, you'll have the opportunity to ask the panelists questions and engage in discussion. So like before, feel free when we get to that point to raise your hand, and you'll get the microphone and will be welcome to ask questions. So before that, we'll turn it over to JD and allow him to provide some reflections and comments.
I figured for sure Andy was going to have something to say. Awesome, guys. So that, I mean, honestly, like for having put you in this position of like, hey, do a logic model that you hadn't anticipated doing, those are really good examples. And I will admit that I gave them tiny pointers, but they didn't really need much help, which hopefully shows a little bit of the somewhat intuitive nature of the IRLM, especially when you have a project going and you deeply thought about all these different factors. Just being able to put them into that framework and link up the different things. So one comment to each about things that I really liked. So with your project, I love that you guys said that doing this actually helped identify additional strategies and potentially even some other just like deeper things about the project. That is honestly one of the most consistent things that I hear, especially when people apply it retrospectively or sort of not as part of a proposal itself, but they don't apply it and they're like, oh, okay, we got to do this. It's kind of funny actually that reviewers don't pick up on all the stuff we forget or don't have, but at least you get a chance to fix it before you get down the wrong path. So I love that you guys reinforced that. Yours was a little different. So very comprehensive, which I don't know if you want to speak a little bit to like, the value of going into the comprehensiveness, but one thing I do want to point out is, and this is a reason why I think that the superscripting or the linking is really kind of critical. You started to see that the complexity of these projects is all over it. Okay, so in many situations, when we write about why we picked our strategy, we say like, well, there's a problem with funding. We have to identify new funding sources, so we're going to do this. And then, hopefully that helps us have more feasible delivery or sustainable delivery. That's really simplified of what is really happening. And I love that your logic model really showed that oftentimes one strategy addresses multiple barriers or leverages multiple facilitators. And I think that you also showed too that sometimes you need multiple strategies to address a single barrier, which we're not always that good about explaining, especially in text, because holy crap, that's lengthy. You could write a book basically about any large complex project, maybe not a book, but a long chapter. Certainly not a George R. R. Martin length book. That's but I really like that was a perfect illustration of this. And then the other thing I want you to comment to as you talk about the complex or the kind of comprehensiveness is which version of the logic model would you want to include in a proposal? The one that's sort of the pared down version that really hits hard the strategies that you're most interested in, or would you see value in having the entire thing, and why or why not? Then I'm going to ask you guys a question.
So to address starting with the first part of it about creating the comprehensive IRLM, as kind of stated, we were doing this after we received the grant. So we actually went through the worksheets that you had created and went through each one of those different CFR constructs and thought, based on this prior work that Dr. Ward has done, what are we hypothesizing we will see, and why do we think this might be important? And in going through that, we realized that it was a lot more things than we initially thought. When I initially was kind of drafting this based on the grant that Dr. Ward had put together and my initial thoughts, it was less thorough. But we really started to see, actually, no, we do expect that these different constructs will impact how this intervention goes, and we might need different strategies than we initially were thinking. Or we might see different things, or we might want to explore this. We actually weren't initially going to ask a question about that in our pre-implementation process, but we might need to because it actually might bring up some new information. And so by doing it in the full comprehensiveness, in some ways it did look overwhelming, but for us who are doing this project and deep in the beginning of that work, it really helped to try to see where those gaps in our thinking were. And I don't know, Dr. Ward, if you have.
No, that was very comprehensive. I don't need to add anything. Well done.
Okay, do you want to use the comprehensive model in the grant proposal, or
Yes, that's what we'll
you
be
do?
doing.
Okay. I won't say why, but
So we do, in the future, that would be the way we'd go. But for presentations, I could see the focus one, like trying to get that across.
or just, I mean, you really effectively essentially used animations, which I can't do. clearly.
I will
to
also
kind of do
add,
that.
I will add in terms of which version. Moving forward, we certainly will go forward with the comprehensive, but we will also see what we're learning that then helps to guide the next step, if you will. But we are sort of speculating that most likely it will be comprehensive.
Fair. Great. Are you
One
ready?
Yeah, that's
Go
okay.
ahead.
One thing I wanted to mention is we tried to put in all the elements, the barriers, so we made it comprehensive. But one of the things we talked about is if we wanted to show this to our advisory board, full of community partners, how do we present this in a way that is pared down
Okay.
and it doesn't get overwhelming and too complex for them? Because we want to be able to communicate this visual map of these are the strategies we came up with, and they are helping us come up with those strategies, as I said, along the way, and these are the outcomes. But then this is too much for them.
Yeah, I think that's a really good realization as you're going through that presenting, especially with all of the superscripting and telling people, here's all the linkages and they're trying to make sense. Yeah, that's a lot. I will say though, here's a little mini presentation, discussants, prerogative. So when we actually do the IRLM with community partners, we actually go through a co-design process, which you guys did, which is awesome, to start to populate everything. But we do the population and we have the IRLM behind the scenes. So the research team who's part of all of the meetings, it's basically the organization of the results. So we don't actually say, hey, here's the logic model, let's fill it out. Because that also is just like, what? Like, I don't like logic models to begin with, and I don't know what the heck this thing is, so good luck. But what the cool thing is if you take all of their answers and the things they told you to fill the logic model in, when we come back after about 4 or 5 sessions, we show them a blank logic model. We explain the underlying generalized theory of implementation, that we pick strategies for specific barriers, et cetera. And we say, here is what you guys have told us over the last 4 or 5 meetings. Let's talk about it. Let's reflect. That is very well received. I will say it's received slightly better by implementers than recipients, because what we have found is that people who work in healthcare and in other delivery systems, and they've actually told us explicitly, they said, this is actually how we think. We've just never used these terms, and we've never had a form. But that we think like this. Like when we're going to try to change something, we think about what are the barriers, like why is this not working as it should be? We think about our solution, and we think, does that actually address the barriers to achieve the outcome? So it's not, this is very similar kinds of ways that a lot of healthcare system people think, healthcare system change people think. So they come along pretty well, but I agree. Like just showing the logic model right off the bat, probably a little jarring. So yeah, I really like that you guys pared it down into the things that were most important and probably tell like the most succinct, relevant story for them too.
Judy, I just want to say thank you for sharing that piece on sort of co-design, because as I think about my cab, they're very actively engaged, if you will, and they would be very open to the idea of bringing the comprehensive and then co-designing in terms of what we may need, there might be additional or what we may need to kind of remove. But I thank you for that idea. I definitely will be reaching out to my cab.
So use the, I haven't used Mentimeter yet, but I think for a cab, especially if it's a larger group, actually going through the strategies like in a PowerPoint and saying, hey, here's a proposed strategy, here's the barrier it's supposed to. First question, is this going to be feasible for you guys, right? It's just like going through and asking and getting real-time feedback. We did ours using like a Qualtrics survey or some like thing that they did on their own, but you could easily, for a larger cab, you could do something like that for sure. That'd be very engaging, but also you'd get data quickly. You'd have 100% response rate because everybody's in the room.
Right.
Make sure they do it.
When we have food, then, we'll get good
yeah.
engagement and response,
Yep. Incentivize with sandwiches. It always works. So my other question to you guys, you've mentioned that you learned something. Can you say a little bit more about exactly like the process or the pieces that you kind of learned about your own project that helped you kind of refine it or change things moving forward?
Yeah, because this is part of a co-design process with our stakeholder advisory board. Some of the strategies that we knew when we wrote the grant, we were like, okay, we need to recruit Black facilitators. We know we need to change the way we train them. But along the way, as part of the co-design, the board actually came up with other strategies. I think, like Martha said, we've had 2 out of 5. And then now we are going back and say, okay, we didn't have these in our strategies. Now let's put it in, and now let's map it back. And what is the mechanism? And you were right. Those strategies, there were so many barriers that were actually addressing that strategy. And the mechanisms actually was also very similar, addressing a lot of the strategies as well. So that's kind of what we learned through this co-design with the board, is that we are going to be adding more,
Yeah.
basically, to the model.
Yeah, I think that's the most common thing is that people realize there was a gap in their logic. There was barriers present that didn't actually have sufficient strategies to address them, or potentially there was a barrier that for whatever reason you didn't think was as big of a barrier as your stakeholders are telling you it is, and that leads you to picking those strategies. So, one other thought that I think might be relevant, especially as you guys are still working on this. So the other step that we did with our advisory board in creating the logic model was outside of the logic model. We had them actually do all of the specification according to the Proctor, Powell, and Macmillan, which was really important. So when you say like you need to do training, everybody here probably thought about a different way to train, or a different duration, or a different modality. So actually having them tell us, how do you want to receive this information? Do you want it asynchronous? Do you want it in clinic? Do you want it on a Saturday? Do you want us to try to offer CME credits? All those kind of things. We had them actually get into that level of specification too. So it wasn't just pick the strategies, which is the first step. But once you have the strategies and you cut out the ones that are totally not going to work, and some of those other pruning techniques that we did to kind of get it down to a reasonable number, we had them go through the full thing. We said, who's going to actually do this in your setting? So define the actor. Here's what you're supposed to do if you do audit and feedback. Can they do that? So we would ask all of those questions to make sure our operationalization and the protocol for we were actually going to use actually lined up with them. So it's just another deeper step in the co-design and community engagement process that you can take on to. I'd better shut up so you guys can ask questions. You want to steal?
So Dr. Ward and Dr. Shiyanbola, nice to see you again. Unfair, I know you all's work very well, and I think it might be important, particularly for this audience, to talk about something that was core to your work. You all have been doing this work for a really long time. You didn't start here. And I think it's important when you talk about the core being building trust with these communities to share the timeline for which you have been building trust with your own and adjacent communities before you started doing this work.
Well, thank you for that question. So in terms of building trust in the timeline, that's been my entire career. I graduated in 2002 from this university, and then went into clinical postdoc to get licensed as a psychologist, then did a research postdoc as well. And during those times, I engaged with the community to better understand the needs from their perspective. In fact, they convinced me to stay in Wisconsin. I was going back to Brooklyn, New York to work as a licensed psychologist. And when I got licensed in 2004, I was the only licensed Black psychologist in Dane County. So I had to stay. They had expectations for me, and I'd been forging connections with them. And so in staying, right, then I continued working with them on the research, and I do community engagement. So I would go to them to better understand the issues from their perspective. And they started telling me, well, yeah, people say you should go in and get professional help, but when we go, we don't see anybody that look like us. And we have certain cultural needs, if you will, and because folks don't look like us, they're not quite understanding what we need and how to provide the level of care that we need. But Dr. Ward, you're like us. You're one of us. We want you to help us with that. And so I've been building trust for the last, I want to say, almost 19, 20 years, if you will. There's one piece I do want to add in there. So I'm from the community. I'm one of them, but I'm also Dr. Ward, and I also have a PhD. So I still have to continuously work on maintaining the trust that I built with them and building with new partners as well.
I'm not going to take it off. I'm just going to say, no, I really appreciate you asking that question, and it's good to see you, by the way. just like Dr. Ward has said, it does take time, and you're absolutely right. Not as long as Dr. Ward, but being in the community for a long time, you have to show up when they ask you to show up. You have to be there when they ask you to be there, and you just don't start from scratch. One of the things we've done is leverage partnerships, even not just showing yourself in the community, but we've used Khan as also another way to be able to. This is a partnership that is already established. The Grace Fellowship Church in Milwaukee, for example, we were able to get them through Khan, and we were able to work with them. But again, it also comes from being there when they want you to be there, even when that project is not going on, and saying, we are here, even though I don't have a grant to submit, and also working with community advisory boards, like we said, and also part of this co-design process. If you remember when I said at the very beginning, we didn't just do literature reviews and say, hey, this is the idea, this is what we want to do. We also spend that time through the original pilot of doing the co-design. I said, we want to learn from you. We want to talk to actual people in the community. What are the barriers? We don't want to go to the literature telling us what the barriers are. You tell us from the community what the barriers are before we can then move forward. And something that we also did at the very beginning is even before we wrote the grants, we were engaging with them and telling us what are the things that we need to be thinking about as we're actually writing the grant. And then now that it's funded, now we can work together, but it started very, very early.
The one other thing that I want to add as well is when the research is done, yes, we publish in the peer-reviewed journals, and we do the national conferences, but going back into the community and also presenting the results there in language that they can understand and make sense of. So I've always done that, and just really greatly appreciate it as well in trust building.
I have a clarification question, and just to make sure I understand, and then I'll have my other question. So I just want to make sure in the Ward-Resnick study, this is a patient-facing, not patient, but a recipient, a person-facing intervention, whereas in the Shiyanbola-Maurer study, this is an implementation strategy. I just want to make sure everybody follows that, right? We were solving different things, which is nice to have that in the panel. So first, did I get that right? Okay, good. Just want to make sure everybody catches on. And then the second clarification question is, both seem to be pilot studies. You're in the formative phases on both ends. Am I correct about that? Yes. Okay, this is terrific because earlier a lot of questions were being asked about what do you do in a pilot study? How do you publish this? And I actually love this panel, and I love that JD's little logic model it is the perfect thing to do in a pilot, among other things you're going to be doing. So I love it. So here's my question, though. The only thing I felt like I didn't catch in both of y'all's interventions, yours is strategy, yours an intervention, is the engagement strategies. And I'm not talking about research engagement strategies, that's a third thing, but can both of your groups speak to what is the engagement strategy? It often gets swept under the rug, and I want to make sure we highlight that. So in your case, in the Resnick ward, how do you keep people coming back to that? That's part of your intervention. We can't sweep it under the rug. Same with you guys. I'll stop there.
That is $1 million question. How do you keep people coming back? Trust, definitely. Starting out with that, building trust in the community so that when we recruit, we actually have someone that we call a community champion, if you will. So she's someone that is known in the community and is able to help us with recruiting, if you will. So we start there. Once we recruit and we bring people in, how do we keep them engaged? As I mentioned, the intervention is being delivered at a church, at several churches. And again, that's a place where people feel safe, if you will. It is easily accessible as well, transportation. Most of the churches have a van. They will be picking people up. They will get door-to-door service, if you will. So we keep them engaged that way. We also have opportunities for retention. When we do data collection, we provide a small incentive to get people to complete the data. We meet weekly over 12 weeks, so over 3 months. We do have staff that will be calling and reminding folks, hey, we have class coming up in a couple of days. Just wanted to give you a reminder. Do you need any assistance with transportation? So we assist with that. We also have folks that may have children that they're taking care of or grandchildren that they're taking care of as well. We also provide childcare on site to assist there as well. So those are some of sort of the practical things that we're doing to support engagement and retention.
Okay, so it's interesting that you asked about engagement because one of the barriers that we saw, and you said you're right, it's an implementation, is many of the Black facilitators who were already trained did not come back. So that means they were not engaged in keeping up with the training that would keep them active. And that is why we only have one Black facilitator in the state. And so one of the things that we've actually now doing is that we are learning through our co-design with the advisory board. They're actually telling us some of the steps we can take to actually bring them back. And then they're also thinking even more systemic of why don't we have something they talk to us about a centralized hub, like a Black organization in the state that can actually partner with the purveyor of the intervention. And that person is the one, that organization is the one that will now be in charge of actually engaging the facilitators, finding them, making sure that their license is staying active, and then we can continue to have sort of this large number of facilitators who stay engaged in the training and are actually able to do the workshop. And so we were not clear, but that is actually one of the barriers we saw, is that many of them are not engaged. But our co-design process is helping us think of some strategies, and they came up with that. In the 2 out of the 5 we've done is, why don't you all do this? Find a Black African American organization that is in the state and let them be a partner with the purveyor organization, and that way they are able to help you get more Black facilitators. And then they are in charge of making sure they stay active too, so that we don't keep having the same problems.
I'm thinking a little bit about something that Dr. Kilborn said this morning, which was that so often you see clinical trials that then don't end up getting implemented afterwards. And those clinical trials were effective. They had implementation strategies to support them. But sometimes the implementation strategies are like, well, we'll provide childcare, we'll provide transportation. And I'm wondering if you've seen, or is there a way to, at the same time, do sort of an implementation real world logic model that moves from what works for an effectiveness study and implementation research into what can then allow it to be sustained or broadly adopted?
Yeah, that's a really good question. I've never really thought about it in that exact way. Usually the way that I think about sort of the translatability of implementation strategies is really more in like the design of the strategy and then also the design of the study, and all the different, like, as you kind of mentioned, all the things that you do within the context of research and whether or not those things actually are transportable. So much like we co-designed the implementation research logic model and try to get feedback essentially, or get input about what strategies are actually feasible for you to do, we sometimes do ask about sustainability too. Like we do talk about how this is going to get paid. Is this usually the feasibility question kind of incorporates some of that. But the other side of it too is really, I've gotten more in the habit of co-designing the actual trial design with community partners. So the bare bones is asking questions like, are you willing to be randomized? And is, implementation as usual an okay randomization, arm that you might fall into? But I've even gotten more into recruitment, obviously looking at the strategy specifically, who does them, what's the flexibility, really informed by the PRACY2 and the PRACY2 PS. So really thinking about at a more granular level exactly how I'm conducting my trial, if that's going to be a much more like externally valid real world evidence type trial or whether it's going to be closer to the efficacy, because as Danny does a really good job of mentioning, implementation scientists do efficacy trials of implementation strategies sometimes. And we also do pragmatic trials of implementation strategies, which hopefully are much more transportable. So you can start to incorporate some of those ideas too into thinking about how the trial design, the strategies themselves, potentially even some of the outcomes are relevant to that too, and how frequently you measure the outcomes, how all of those actually could be more or less pragmatic. So that's what I usually do personally, is kind of incorporate more pragmatic design thinking. And I've never really tried to put that in the logic model, but giving me something to think about there. Probably a way to do it. We probably have time for one more question or comment. Yeah. We have one right up here in front. We have two people got excited.
Hi. So to expand a little bit on the point that was brought up, that you don't just start one of these projects, establish a relationship, and kind of gain trust at the snap of a finger, right? That doesn't happen. And not only is that infeasible, but there's, I don't know, there can be very good intentions, and yet I think in order to make that genuine, you really need to have established yourself. So I'm wondering if maybe, and I think that you brought it up, Dr. Shiyanbola, that I don't know if there would be some way of, for these health equity that now, you slap health equity on almost any conference now and you triple your attendance, right? So I'm wondering if there's been any efforts, or are you aware of any mechanism to make that sort of scale up, but with that trust built in? And I don't know if that would be sort of having like a clearinghouse, because there's also this concept of health equity tourism, that all this money is flowing in, all these people want to do the right thing, but we're sort of muddling through it. So I'm wondering if there's some way of kind of providing a runway for that to be, I don't know, more equitable, more of a partnership, and sort of remove or facilitate that issue of establishing the relationship, because we don't have 20 years to build a relationship, right? It's great that you've done that, but.
So I can, and I'm sure others can say something. I mentioned Khan as an example, right? Which is a community academic agent. Sometimes you want to be there for the community, but I think there's a way to get started by partnering with community academic organizations like Khan. Center for Community Engagement is the Collaborative Center for Health Equity, the CCHE, also through the CTSA. These are initiatives that are already available through CTSAs that have already built that trust, have already established some relationship with the community. And I believe investigators should actually come talk to these organizations, so that, like you said, you don't have 20 years and you still you still have the individual responsibility, but if you don't have to start from scratch also as well. And some of these initiatives are already in place to be able to help you get there and give you a little bit of a leg up when you're actually starting with the community. However, something that I would say is you also have to do the process, because even if they can help you, like, oh, we already have established community partners on ground. We've already built this trust with all these barbershops, and we've already built trust. We've done the work already. If you don't show up as an investigator, then it doesn't really work. So it's kind of both.
I certainly agree with everything that you said. The additional thing that I will add, which I've heard from my community partners, one of my colleagues have this saying, come and visit me when you don't need something. Come and visit me when you don't have an ask. And so what we do is, we're doing research. We go out there with them to get assistance to recruit and so on and so on. And they're saying, just come and visit us. Just come. We have meetings. Some of our meetings are open meetings. Just come and just join with us. Hear about what we're doing. Hear about what's happening in the community, and do that a few times to begin to forge those connections. So definitely recommend that. And then with that, then asking them, how might you be able to assist? What are some things that they may be needing? They may need someone to come and talk about how to better manage blood pressure, right? So, and that's your area of expertise. And so when they have a wellness session, you go on down and you do that talk. Or they may have other areas of interest that may match your expertise. You say, yep, put me on the list and I'll come down and talk. So those are the things that you can do now before you get the, the NIH grant or the other large grants. Those are things that you can do just to be in the community and connect with folks again without an ask.
I mean, I'd like to underscore that last point because I do hypertension research because the community partners that I've worked with for multiple years said that's our issue. I didn't know anything about it. I still know very little. But I have both pediatric and adult hypertension because my community partner said that. They said this is our priority. So I don't go to them saying, hey, I have a grant opportunity anymore. I go saying, hey, I've got bandwidth. What are you guys interested in? And if I can't help, I'll try to find somebody who can. But yeah, that's been really successful.
I think we're right now. Thank you for the great discussion and conversation. Looks like there's some snacks in the back. We have about a 15-minute break, so we'll see you in a few minutes.